Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Good afternoon, THOR listeners. My name is Andre Kapp. I'm a hematologist and THOR executive committee member. I'm here today at Solstrand, Norway for THOR 2025. It's my great pleasure to present today's podcast with Dr. Nikki Curry from the University of Oxford. We're here today to talk about hemorrhagic shock and its effects on the endothelium. So Nikki, first off, I think we need to talk about the endothelium, remind everybody what it does and why it's so important in this setting.
So the endothelium is basically the continuation of a single blood cell layer that covers the whole of the arteries, veins, and the capillaries in between. It is a continuous layer that acts to keep blood flowing, and it sort of separates the blood, if you like, from the tissues underneath, and it keeps all of our sort of plasma and so on inside the blood vessel, and it maintains homeostasis and prevents us forming clots and prevents inflammation in general.
So Nikki, tell us what happens to the endothelium when you have a massive hemorrhage and you go into shock. What's going on there that's so important?
Okay, so there's multiple things, and with trauma there's always multiple things going on, and it's slightly dependent on the type of injury, etc. But in general, it is thought that when someone has severe injury, there's direct tissue damage, so there's direct mechanical damage to the endothelium, plus there is shearing and loss of some of the blood vessel itself. On top of that, patients will be bleeding out of their injured site. They will develop low blood pressure, hypotension, and the patient themselves will also release quite a lot of catecholamines, so epinephrine, norepinephrine. In addition to that, the low blood pressure will cause hypoxia. And so there are multiple things that cause either direct damage to the endothelium or what is perhaps viewed as systemic damage to the endothelium, which causes basically activation of the endothelial cell and damage to something called the glycocalyx, which in simple terms is like a gel-like structure that overlies the endothelial cells. Varies in thickness depending on which part of the body you're in and whether you're in an artery or in a vein. But that gel-like structure gets damaged as well. And we're not really sure exactly what happens to it, but essentially it's either bits of it are sheared off or some of the direct damage causes it to be lost as well. The glycocalyx, and there's been more evidence about glycocalyx with hemorrhagic shock and trauma, but the glycocalyx essentially has an added effect of sort of, protecting the endothelial cell. So it's a structural protection.
So it's fish slime on a fish.
No, absolutely.
Helps keep the fish slick in the water. This is like slick for the blood, right?
And it keeps the red cells, the platelets away from the surface of the endothelium. It also sort of, any activation, inflammatory cytokines, chemokines are caught in it. So the endothelial cell underneath is protected. When that glycocalyx is lost, there is direct sort of blood contact with the endothelial surface, the hypoxia, all of these other things then activate the endothelial cell surface. So there are multiple things going on, which I think we don't fully understand, to be honest. But what we know is in patients that have hemorrhagic shock, we know that they are much more likely to get endothelial cell damage. They're much more likely to get loss of their glycocalyx, and they're much more likely to end up doing pretty badly in a clinical setting, having either poor outcomes because of increased bleeding or later down the line from multi-organ failure.
Right, so the endothelium, I guess we think of it as preventing, keeping the blood in the blood stream as opposed to in the tissues, right? So it's sort of got a anticoagulant type effect as well as a barrier function, right? In keeping fluid where it's supposed to be. So those things break down is what you're saying. In addition to that, the endothelial cells, I guess, also can help maintain flow by secreting certain things like TPA, right? And that gets released a lot, potentially contributing to bleeding through fibrinolysis. So that's another element that in hemorrhagic shock we have to worry about.
No, you're absolutely right. So there are what the actual endothelium then does when it is activated in terms of increasing, and you're completely right. Inside your endothelial cell, there's a whole bunch of stuff, and there's little organelles that contain, or packages that contain things. TPA is one of those, and we know that immediately after injury, everyone will be aware that one of the sort of fundamental reasons why patients bleed is because of increased clot breakdown, increased fibrinolysis, which is caused by endothelial cell damage and really rapid release of these pre-stored packages, and you get release of TPA, which then causes plasmin to break your clot down. And so I think being able to understand how that happens, or to be able to really think about mitigating some of those changes, is really important,
So really bad then. So hemorrhagic shock, if damaging the endothelium, removing that homeostatic regulator is terrible, because so you've got increased bleeding risk with fibrinolysis, you lose the glycocalyx, so now the blood's in direct contact with the endothelium and potentially tissues underneath, which means it can stick to those things and cause clotting, which, as you said, can contribute to multi-organ failure downrange. And you've lost the barrier function as well, so you can get leakage. How does the leakage affect patient outcome? Leakage of fluid from the intravascular space out. I mean, you get the edema formation and...
So this is, so the endothelial cells, normally when they're in health, they are really tightly bound to one another in most places outside the liver. And they have these, it's what's called tight junctions and adherent junctions. Those are things that normally really regulate how much fluid or sometimes other proteins go across. Albumin or some of the other proteins actually go through the endothelial cells, but some of the liquid from the plasma, etc., from your inside your blood vessels goes through the tight junctions. What we know when endothelium is damaged is that those tight junctions become much more sort of relaxed, if you like. Relaxed is the wrong word. They're damaged, and so the endothelial cells separate. And we know that the vascular component then leaks out into the tissues. There's ongoing tissue damage. And we know in those patients, clinical outcomes are much worse. And it can be very difficult to treat those types of patients. So I think there's multiple areas where the endothelium really has a clear role in the damage of, and in the outcome, the clinical outcome of what happens to patients. I think also from a haematology point of view, there is some of the proteins that sit on the surface of the cell are really important from the clotting point of view. So you talked about when the glycocalyx is lost, blood comes into contact with the endothelial surface. We know that when the endothelium is activated, you get upregulation and downregulation of quite a few important proteins. And some of those are like tissue factor that activates clots. You get loss of things that prevent that activation of clot. That's in an immediate setting. We also get changes to a protein called thrombomodulin that's very important in pro and anticoagulant effects. And not only is that important in the clotting side of it, it also alters those tight junctions. It alters how much von Willebrand factor is around and the overall quiescence of those cells. So I think there's a huge amount of stuff that we need to learn about that we currently don't know.
Yeah, and a critical and even kind of perverse effect here too is that as you have hemorrhagic shock and all this tissue damage, you generate a huge amount of thrombin.
Yeah.
which directly activates the endothelial cell and makes it have this more sticky phenotype, prothrombotic,
Yeah.
leaky.
Yeah.
So the effect of thrombin and all this, which you need to stop the bleeding,
Yeah.
on the other hand, is actually causing a problem at the endothelial level. So it's a really sticky problem, if we can say that.
Really complex, yeah, that's right.
So we've set the stage here where you have massive loss of blood, shock, activation of coagulation, loss of glycocalyx, the endothelium's damaged, it becomes sticky instead of letting blood slide through, the tight junctions are damaged, you leak fluid into the tissues, you get edema formation, which all of this contributes, microvascular thrombosis because it's sticky. So all this contributes to multi-organ failure down the road. Very bad. So right now, when we think about resuscitation, so we want to prevent all this.
Yeah.
So obviously, if you could prevent the shock, that would be great. So the key thing is keep the patient out of hemorrhagic shock to avoid all these terrible sequelae, right? And we think that probably the best way to do that is through use of blood products. But one thing that's been observed is that plasma seems to have some regenerative, or plasma-containing products, seems to have some regenerative capacity for the glycocalyx. Do you want to talk a little bit about what's been observed in that regard?
Yeah, no, absolutely. So I think there's been work that has been done in mostly preclinical models, but just in terms of how do we as clinicians really diagnose, if you like, endotheliopathy, and the way that we do that is how we do many things, which is using biomarkers, so blood sample results. And we will say that somebody in general has endotheliopathy if they have a high level of circulating one of the glycocalyx proteins, which is called syndecan-1. So there are other things as well, but that's often what has been used. And so we know that patients that got a severe hemorrhagic shock have high circulating levels of syndecan-1. And so in the mouse model particularly, when mice have had injury caused to their blood vessels that causes the glycocalyx to be lost, what has been shown is that if you give that mouse plasma, so fresh frozen plasma, or in actual fact, if you give them, in some instances, cryoprecipitate or fibrinogen-containing compounds, there is a reduction in both the loss of the thickness. So the glycocalyx is not as thin if you give the mouse plasma products. And it's also been shown that there is some degree of repair, looking at the amount of syndecan that is found in those endothelial surfaces. Has that translated? Are we able to translate that into humans? Have we seen that? Difficult to answer that question, I think. I think that work needs to be ongoing and needs to show those comparators.
Right, we'll just borrow your endothelium for electron microscopy, thanks.
I think that's the real
patients object
difficulty.
To that sometimes.
I think that is the real difficulty. And so, so not only have they shown that the glycocalyx is protected, it remains a bit thicker, but they've also shown that the vascular, what's called permeability, so the leakiness, is reduced. So that has been shown in preclinical models. We also know, as has been talked about, that blood component therapy, you're much less likely to get overt leakiness in your patient group when you compare it to historically when patients were given a lot of non-blood products for resuscitation.
Crystalloids,
yeah.
Right.
So I think we've got some sort of observational data that these things work, but it's very difficult, as you say, to translate this into humans to start looking at their endothelium and how can we do that in a real human model, I think is quite hard.
So to recap then, hemorrhagic shock, bad for the endothelium, makes it sticky, makes it leaky, contributes to multi-organ failure, mortality, etc. Resuscitation with crystalloids, you get a lot of leakage because they don't stay intravascular. We've shifted to blood product-based resuscitation, particularly including plasma and platelets to perhaps to some degree, observed that there's less of that edema formation, less ARDS. So that's good. The mechanisms by which that happens, maybe involving the glycocalyx, although that's still sort of uncertain. And of course, the other problem is that plasma contains many things, and so to understand what element of that is directly contributing to glycocalyx preservation, barrier function, who knows, right?
Yeah.
Now, the interesting thing to do to move beyond, purely blood product-based resuscitation and maybe directly target endothelial injury would be to understand some of the signaling pathways, the key proteins, receptors, et cetera, that could be targeted, that would be druggable targets.
Yeah.
So where do you see the future of this field going in terms of finding those druggable targets? Like, what are the key pathways that people have looked at that maybe are promising?
That's a very big question. Thank you. I think it's so. There have been a few things, and quite a few of the things that have been looked at fall outside of trauma. So, for example, if you look at the world of sepsis, where again you have damage to the endothelium, mostly because of bacterial or other things, but ultimately due to similar cytokine damage and inflammatory damage.
Ends up in the same place.
Yeah, I think so. There have been, because of the inflammatory processes, there have been sort of evaluation of things like anti-TNF or anti-IL-6 as things to try to reduce inflammatory activation of the endothelial cell. We also know that there's been some work looking at the release of von Willebrand factor from endothelial cells and ADAMTS13 that breaks it down. And so trying to look at the effects of those in relation to endothelial, microvesicle release. In terms of where I see things going a little bit, because I am a haematologist, so forgive me, but you are too, so that's fine, is what I want to know is, are we able to alter some of the changes that happen to the endothelial cell? So, for example, we know that immediately after injury, there is this release of all of those proteins that we talked about. But we know that some of the increased stickiness, if you like, takes a little bit of time to happen. If you look at the alteration in the proteins and the activation of the genome within the endothelial cell, you can see changes over the first 24 hours of certain proteins that relate to the endothelial cell surface, such as thrombomodulin, such as ICAM1, VCAM1, which are proteins that are involved in inflammation and coagulation. And there's also activation of pathways that are regulated by NF-kappa B, angiopoietin, and so on. And I think those are the areas that if we are going to be trying to impact that later effect, so the multi-organ failure effect that's caused by micro thrombi and so on, I think there needs to be something that we're able to target that is within a time scale that we can get to the patient to target, which are these later time courses, whereas the release of TPA, if you like, is almost immediate. And as you say, the way to prevent that is to prevent shock. I think the way to prevent some of the multi-organ failure is to look at what happens inside the endothelial cell that we can then target. And I think that's where our focus should potentially lie.
So you mentioned thrombomodulin. Thrombomodulin and protein C work together to both reduce thrombin generation, and protein C has a direct cytoprotective effect on endothelial and other cells. That seems like it might be a particularly promising pathway. You could even imagine a scenario in which you would have, by increased activation of protein C in a controlled way, shutting down the upstream generation of this endothelial activation by reducing thrombin generation when it's no longer as critical to hemostasis, but it's now shifting to contributing to this sort of inflammatory state,
Yeah.
as well as direct cytoprotective effects on the endothelium. That could be a very interesting approach.
I think so, and I think, but the difficulty comes because my lab we're looking at some of that. But what happens is that there is downregulation of thrombomodulin as well within the cell, and by downregulation, you then lead to continued activation of that thrombomodulin. So the question of giving it would be actually you need to get it inside the cell or onto the surface of the cell to do its work, rather than just simply infuse it. So I think that there is a whole bunch of really mechanistic work that needs to work out how to separate out what happens in the plasma and the blood to what happens at the cell surface and which does what.
Sounds like a great molecular engineering project for somebody.
For somebody, yeah, exactly.
Well, fantastic. Nikki, thank you for sharing these insights with us. I hope our audience has appreciated some of the critical final common pathways of pathophysiology of hemorrhagic shock that are the subject of really interesting investigations that will hopefully yield new therapies to complement what we give as blood products and improve outcomes for patients. So thanks for sharing that with us today.
It's been a pleasure. Thank you, Andre.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.